of his orbits performed. No identifiable foreign body was localized within the orbit, and he was brought into OT for repair. Intraoperatively, 2 lashes were found within the anterior chamber, but no external ocular foreign body was found. An anterior and posterior capsular breach was noted on aspirating the soft lens material, and an anterior vitrectomy was performed. The patient was left aphakic, and the AC reformed with viscoelastic. At 4 months post-injury, his vision remained poor with a best corrected acuity of 6/45. He was planned for a secondary lens implantation, and on examination at the time again, there was no relative afferent pupillary defect, and his fundus also appeared normal. Biometry was unreliable in his right eye, so lens selection was based off his left eye. A 3-piece lens was placed in the sulcus as the posterior capsule was compromised, but the anterior capsule support was still secure. Sutures involving the central visual axis were removed. At 8 months post-injury, and now 4 months post-secondary lens implantation, his vision, however, still remained poor. In the interim, further sutures have been removed in an attempt to improve the vision, but it remained hand movement. Pentacam assessment revealed irregular astigmatism of 2.9 diopters. At this stage, considerations were made for a corneal transplant. His endothelial cell count showed a healthy cell count of about 2,200 with reasonable morphology. At 1 year post-injury, the patient underwent a manual DALK. The decision for a DALK was made based on a combination of factors, including the patient's age, relatively healthy endothelial cell count, the patient's occupation, and his future needs, as well as surgeon preference. During the operation, a slow leak was noted at the site of the previous corneal wound, which was managed with an intracameral air bubble. At 1.5 years post-injury, his graph remained healthy and clear. There was no relative afferent pupillary defect, but his vision did not improve at all with subjective refraction, and it still did not improve even with a trial of contact lens fitting. Given that his fundus appeared normal, a decision was made to proceed with electrophysiology to try and identify any further pathology. This slide was prepared with the assistance of Prof. Grangholder and shows the relevant results of the patient's electrophysiology. Of note, the patient's pattern VEP was subnormal and delayed. The presence of a pattern VEP is inconsistent with the reported visual acuity of counting fingers, as counting fingers acuity would have expected to have no pattern VEP response. The pattern ERG is markedly abnormal in the right eye, which is consistent with severe dysfunction anterior to the retinal ganglion cells in the visual pathway. Combined with his full field ERG showing no significant abnormality, this actually suggests a possibility of macular pathology. Though the subnormal pattern VEP in the presence of counting fingers vision do indicate possible non-organic overlay. Currently, the patient has returned to work and is actually due for follow-up in 1 month's time, where we plan to do further investigations to investigate for possible traumatic maculopathy. This brings us to our discussion points that we hope to raise with the panel. Our first discussion point is, in the absence of an identifiable intraocular foreign body from both CT and intraoperatively, would this still be considered a penetrating injury versus that of a rupture? This affects the prognosis on the ocular trauma score, and if this was the primary score being lower, would this affect your approach to his management in the later phases of his care? Are we going to discuss at this stage, or should I raise the other discussion points?
I mean, I think it would be still penetrating. I think it would be a penetrating injury because it seems that it was sort of a linear laceration in the cornea, as opposed to sort of the rupture, which is a sort of a almost like a blowout under at the weak point. So.
Okay.
And then it's interesting that's amazing that you could do the DALK, because with the full thickness laceration, but then when you said there's a slow leak, that's good that it was slow, because I do agree that if you can do the DALK, that's the preferred technique.
Okay, thank you. Which brings us to the second point. If faced with a similar case, what would your preferred primary repair in the initial setting be? And when would you consider additional procedures such as the anterior vitrectomy, lensectomy, core vitrectomy, etc.?
Dr. Rajiv?
I think what your approach of a primary surgery just being a closure and then doing it as a staged procedure, unless the anterior capsule is ruptured or no, the lens integrity is not there. Otherwise, doing it as a staged procedure would be a good idea. Only one question is when you saw the retina, because you have a OCT which is quite late, but after your surgery, how long the OCT was done, after how many days of injury?
That OCT was done about 4 months after the first injury, and it was done just before the secondary lens implantation.
Sure. See, because one of the things, if you are considering it as a Berlin's edema, can probably initially in acute stage, it might happen. And that over period of time, it can give rise to a photoreceptor loss or a damage there. But your structural OCT at 4 months didn't show that. That was something which the macular area seems to be looking good in that OCT.
I think optic nerve is not optic atrophy.
And Dr. Mukherjee is on the line, I think. Dr. Mukherjee can comment on the discussion point, penetrating injury versus rupture. Dr. Mukherjee?
Dr. Mukherjee, can you hear us?
Dr. Mukherjee?
Is there on the...
I think he is muted himself, or
Yeah, he's muted.
that may be the reason. So we can call him and...
Okay.
Okay.
What is, just excuse, what was the age of the patient? I just forgot.
24.
24. So the only thing, if it is a young child, you are more worried, because if 4 months, amblyopia, other things you may consider, but 24 years is nothing. But that's something we need to keep in mind, that we need to do a early recovery in these patients who are children or amblyopic age group.
I think optic nerve we have to consider. There can be possibility of associated optic atrophy. Partial. So vision.
Dr. Graham Older, what do you think about the pattern ERG, pattern VEP, which you suggest, because there is a suspicion, people are thinking probably it may be an optic nerve injury.
So your expert comments, Graham.
Thank you very much. Am I audible?
Yeah.
Yes.
The findings are not those of an optic neuropathy. The pattern ERG tells us that the problem, because P50 is almost undetectable with the standard field and is just present with the large field, that the problem is anterior to the retinal ganglion cells in the visual pathway. So the findings that you see on the VEP, where there is delay, there is amplitude reduction, are consequent upon changes which are taking place anterior to the optic nerve in the visual pathway. What's relevant, and I think this is something that David brought out, is that the level of visual acuity reported by the patient is not consistent with any pattern VEP being detectable. Counting fingers vision should not have any pattern VEP. So there is evidence of non-organic overlay, but mostly it looks far more like a maculopathy than an optic neuropathy. If this was an optic neuropathy, then we would see preservation of the P50 component and loss of the N95 component, because the N95 component arises in the retinal ganglion cells.
Thank you, sir. Can I just see the OCT once? Can you just show the OCT picture? Yeah. So 4 months post-injury, I see even the external limiting membrane, the ISOS and the photoreceptor seems to be pretty good in this. Outer layers are pretty fine, outer retina. Inner retina is also, so if we expect that a maculopathy will cause a change, it is responsible for such a low acuity, and 4 months, this OCT doesn't match with the maculopathy. That's what I have.
Right.
Yeah. Can I add a little further on this? It certainly doesn't explain the reduced acuity, but we've already established that the acuity is not genuinely as poor as was reported. The presence of any pattern VEP suggests an acuity probably not worse than 636.
Yeah.
As for the normal macular anatomy, that does not mean normal macular function.
I agree. I agree with you. I fully agree with you.
We should not rule out the possibility of a pre-existing amblyopia. A number of people would not be aware of a unilateral decrease.
Right, sir, right.
That wouldn't explain the loss of the Patney-RG.
Yeah.
There is a loss of Patna ERG.
Patney-RG is almost undetectable.
Okay.
And that doesn't happen in amblyopia.
So what explains it?
It's anterior to the ganglion cells. So it's far more in keeping with a maculopathy than anything else.
Yeah.
But they need to do some current
Yes.
macular imaging and do some macular testing.
Correct. That's what the autofluorescence or a fundus photo. Do you have a fundus photograph of this patient? We can get some idea about RP. Yeah.
Unfortunately, we don't, but that's what's planned at the next visit to focus on his macula.
Absolutely.
And
Basically,
there is no RAPD changes also. The patient does not have any RAPD. So you found that
He's been checked at multiple visits, and we've never been able to pick up an RAPD at multiple visits.
I think that those are more of an optic nerve trauma.
Ray, would you like to make any special comments as consultants in charge?
So Dr. Mukherjee?
Sorry, me. Is it okay? Yeah, I was trying to tell you. I mean, basically, we couldn't find anything.
Good evening, everybody.
Hello, can you hear me?
I did not get the link before. So
Yes.
this is time to come to this meeting. Sorry for that. I'll take part from the next case onward. Because this case I have not heard.
Very good case, a very good case, and definitely in your next visit, when you do a little multimodal imaging on autofluorescence, probably a fundus photograph, that may give a pretty good idea about what we are dealing with, because we do expect some macular structural changes which you may pick up.
Well,
because we are suspecting maculopathy.
So, David, if I can add, Rupesh here, very good, well presented. So as I think your question number one, when you post, and if you go back to that question, so I think that becomes quite relevant here. And as you say, penetrating injury versus rupture. So if you go back into the history, if you go into the history of the trauma, so this becomes quite relevant here. So can you go back into that history slide, the mode of trauma? Now,
so the mode of trauma, I haven't written it down.
So correct.
It's a metal bolt.
Yeah. So let me just come there. Sorry. So yeah. So now, if we have to go into the history, and it becomes very interesting about how a penetrating injury can happen with a metal bolt and all. So that's what I've been thinking. So there can be a possibility, though the injury, if you look at it, it looks like a laceration and definitely looks like a penetrating injury. But for a metal bolt to cause an injury like this is something a little bit not fitting into the history and the pattern. Let's say if you say someone says scissors injury or with a knife or with some kind of a pointed thing, then I can understand. So now if we think about a metal bolt with a sharp end and then sharp end has scratched through the cornea, then we can understand this is laceration. But what I'm thinking, that metal bolt would have caused some kind of pressure on the eye, resulting into coupe counter coupe, and that coupe counter coupe mechanism has opened up the cornea from inside out. Probably that is which is explaining, and it comes back to that question of whether it is a penetrating injury or whether it is a rupture. So I think even if you say sometimes it's a penetrating, it may not be pure penetrating. Probably this is a mixed type of injury, which has some component of the rupture component and as well as a penetrating component involved. And what rupture component would have done is, whether it is at the level of Muller cells or something, which Professor Holder can correct me. And at that level, there is some kind of a rip which would have happened in one of the layers of the retina. And you've just shown a single line B scan. What we don't know is the other line B scan. So that line was running through the fovea, but there can be sometimes some bit, one scan up, one scan down, we can see some abnormality. We have seen cases of hydroxychloroquine retinopathy. I'm just giving you an example where there are very fine changes which are often missed on this single scan. And therefore, one of the things which we advocate every time we look at hydroxychloroquine retinopathy.
You have to keep time, huh?
So these are some of the points.
You need to stop them. Go ahead, stop them and move on.
Thank you.
Thank you.
Thanks. Do we have time for the last two discussion points, or do we need to move on?
And any other, I think we had a good discussion on this case. Shall we move on to the next case, please?
Yes.
Okay. So thank you, Dr. David, and thank you, Graham and all, for the nice discussion we had on this. So next, Dr. Mehul, can you please invite the next speaker?
Yeah, next speaker is Dr. Shakeen Singh. He is the professor in Amritsar, and he is a very well-known traumatologist. He'll be presenting a case.
Traumatic PKP, wound dehiscence. Dr. Shakeen, we are not able to hear you. You have to unmute. Sai, can you unmute?
Dr. Shakeen?
Yes.
He is muted.
You are muted, I think.
I think. Okay, done.
Yeah. Sorry.
Done. Right.
Sorry. Is the slide available there, sir?
Yeah, we are able to see. Please go ahead.
Thank you. I must thank Dr. Ganga and my parent body OTSI and efforts to give me this opportunity to share this rare case, traumatic wound dehiscence. In fact, we have two patients to report here, and we know the usual causes. I would not waste time here. The mechanism is usually traumatic or maybe sutures. Interval it's taken 18 weeks to 7.5 years. And characteristics usually they are associated with the iris prolapse, lens extrusion, vitreal loss, vitreous hemorrhage. Visual outcome in these patients is usually very less, just in hand movements or less than that. Major issues to dehiscence is sight. Commonly, it's inferior more than superior, temporal more than nasal. Age, it's more seen in young age. Extent more than one quadrant. Incident is 0.6% to 6%. So this is one young boy on 28 years.
Join kar rahe ho meeting? Busy.
And this is the post PKP case one, around a year. How he has presented to us. This is the post trauma. This is the blunt trauma occurred while he was playing cricket, and he has reported 3 days post trauma. And examination, I suppose, is very important in these patients. And the inspection of the wound is already we have an exudate, and we need to be very careful when you look for the outcome. Margin wound, prolapse part, RS, vitreous, lens, or anything else. Luckily, it was plugged with the exudation, and the margin was cleared. So attempt was to repose it. So important aspect what I believe is to clear the iris out of the wound. Angle needs to be cleared. Most of people, they do prefer interpreted sutures would help us later on. But I'm more convenient, comfortable with the continuous. So I preferred at that time with the continuous suturing. So it's well sealed. Bury the knots. And we need to see the clarity from all other sides. Making a wound well tight, equally forces are across. side port entry to be very sure that iris is not incarcerated into the wound and the angle is clear. And this is day 1 and day 7. Patient lost follow-up after 6 months. So it's another patient with a trauma dehiscence, an old man. This is a post PKP day 1, a 1 month, 3 month, 6 month, 7 month, 9 month. He was doing good for 18 months. It was reasonably good 624 vision. He presented with a trauma while working in the field, and this is the how he presented to us. Luckily, there's no much damage to the anterior chamber. So after thorough cleaning, preparation, inspection of the wound, there was some capsule which was there with a cortical matter. So this time, I preferred the steel sutures, the interrupted sutures. Steel sutures, they give a better closure, better tight. So we have been accustomed with the steel sutures in other surgeries. So I find these are better for wound repair or the corneal wound repair. So after you making the tear chamber, ensure that the iris is not there tucked in the wound anywhere. So this is a day 1 post-op. This is a 3 month and 6 month post-op. Around a year follow-up. And these patients, they have a vision which was better than 660 and still on follow-up. One of those is on follow-up. I believe prompt and timely intervention will prevent many complications and will deliver better results. We have been monitoring because of the scarcity of the time. I could not document all those parameters which we have been following, like IOP and OCT, which have not been sharing. OCT in the second case was possible. It was not possible in the first case, but they are reported with a good vision. Thank you.
Thank you, Dr. Shakeen. May I request Dr. Fasika if you can give some expert comments for this for the discussion of this on this case.
Sure. So I think very nice suturing there. It was beautiful. But in terms of PKP, Dr. Singh, what is your what is your preferred choice for like DALK versus PKP? Because I know when we talk about a full thickness corneal transplant versus the DALK, the visual acuity outcomes are not superior in DALK. But I think in trauma is where we see the superiority of DALK. So maybe you could comment on that.
Definitely DALK is better than PKP. In our kind of setup, we are often present with the patients which are really not very good conditions. So most of the cornea, they're totally scarred or vascularized. In those patients, I would prefer a PKP. Definitely DALK or DSEC, they are preferred. Component keratoplasty, they are my choice otherwise, but unfortunately it was not possible here.
Yeah, we see like so many DHIS-PKs and also ruptured extra cap wounds. So I think the small incision tunnel is much preferred, but that's that we see at least, I would say, 10 per year at our eye trauma center. So and then Dr. Ganga had a question about the role of protective eyewear in PKP eyes, and that's a very important point. Actually, for polycarbonate glasses, it seems the uptake is very poor in patients with eye injuries. So I think that would be an interesting area because it's critical in terms of preventing injury to their good eye. And I don't know why there are barriers in terms of because I think we recommend it, so I'm not sure why there are barriers to the wearing of the polycarbonate glasses. And then the other thing is falls. I think as we see in the epidemiology of trauma, falls is going up and up. So if patients have a history of a full thickness corneal transplant, we really need to talk to them about their home, making sure they don't fall, because then it can be devastating.
So what is the incidence or chances of graft rejection in such cases? PKP graft rejection.
You mean in the setting of trauma or just overall?
not in this particular, such kind of cases where there is a dehiscence of wound, graft dehiscence is post PKP, graft dehiscence is there, or the opening up of the graft is there from the.
I think it would be, I'm sorry. I think it would be more a graft failure, loss of endothelial cells.
So not very good in these patients with the dehiscence. Usually they don't recover better vision. But we were lucky to have both of these patients. They hadn't had movements. Usually they come just a right perception. So maybe you need a regraft there.
So thank you. Dr. Mukherjee is there. I think he has some network issues. I just called him to be in. So he says that he is having some network issue. And so internet connection is not good. That's what he said. So let us move to the next case. Any other discussion point? Any other point to be discussed? Any other? Dr. Grover, you want to add to that? Dr. Kasturi?
Yeah, Dr. Shakin, that's a beautiful presentation. I just
Thank
have
you.
a query. Why do you feel that the steel sutures are better than the other sutures that we use? What makes you feel this is a better suture on dehiscence?
Like ma'am, I have been since long we have been working with Dr. Daljit Singh. Since long we have been working with the steel sutures. In fact, steel suture is one of my choice. Even he used to do PKP. I have few patients with the vascularized cornea in which I have used only the steel sutures. They give you very good closure, a very appropriate tight closure. I'm using 10 on nylon otherwise, or Proline, but I prefer these are they're going to give you better closure. And in cases of a compromised, a threat of vascularization or resection, these steel sutures are better inert. And mind it, they are non-magnetic.
Dr. Sakin sir.
Yes, sir.
Rupesh here. Yeah. I had one case where when I was at LB Prasad and I was trying to repair one of those post PK dehiscence as like you had repaired wonderfully. So I had a nightmare. I had only 2 sutures to place. So one thing I struggled, and probably it will be good for the audience to listen also. Which will be your portal of entry to inject viscoelastic? Will you create a separate stab entry from the corneal limbus junction, the limbus, or will you go with the same host graft junction? Because that was my point number 1 where I struggled. So which one you suggest for the audience? For the
Dr. Rupesh, what I personally believe and feel, we need to thoroughly examine the wound, dehiscence. If it's a healthy, not too much odometers, so chances of dehiscence is less. So we can use after thorough washing, if you can find a place between the iris and the anterior chamber in the cornea, without damaging the either border of the cornea, you use that. Otherwise, it's always preferred to have a side because it's unhealthy. It's a controlled entry point.
Because in my case, I went through the wound dehiscence area and I managed to cause a DM detachment there, and which was otherwise intact because I did not realize the DM attachment at that the graft can be much poorer as against when you go from the limbus side where it can be quite intact, quite nice one. But here, as soon as I touched, I think I injected visco, probably it just stripped the DM. And therefore, I said it was a complete nightmare where I thought I'll be out with 2 sutures, but it was a complete nightmare. So therefore, probably for some of the things, better to call surgeons like Dr. Sakin Singh, Dr. Pasika, or Manitos, or some cornea surgeons to help you out.
When you enter from the sides,
again,
we don't know the exudation in the anterior chamber has a stiff synecdoche.
Okay. Yeah.
So we need to be very careful when you are injecting from other sides that may let the things prolapse further, like the iris or something else. So we need to be careful in examining the anterior chamber content.
Yeah.
So we'll go to the next case. Yeah, please.
Thank you.
Can we call upon Dr. Ail for a presentation of case with the post-traumatic endophthalmitis with corneal ulcer?
Okay.
Dr. Mehul, are we getting the questions from the audience? Because most questions there on the audience on the YouTube I don't know, are we able to see? Because I asked Sai a few times, how do we see if audience is trying to ask any questions? Because I asked 2 questions there. I don't know.
One moment. He has provided one link. That link I will pass to you. You can open that link.
I've got a link. I posted 2 questions there. And I don't know where is the questions going. I just posted just for checking, but I don't know where it is going. Can we?
Let me see.
We will take those questions at the end, doctor. At the end of the session, because that list we'll make a list at the end and then we'll discuss it.
Dr. Shakeen,
Dr. Aim,
can you stop your screen share, please, so that the next speaker can.
Thank you. Hello, everyone. Okay, so let me share this. Thank you very much to the organizing committee and to the OTSI for inviting me, and Eid Mubarak to everyone celebrating. I'll keep this short and sweet. I'll be presenting on a polymicrobial post-traumatic endophthalmitis. No financial disclosures. I'd like to acknowledge my colleagues, Dr. Sujaya Singh, Lim Yiwen, and Fazliana Ismail. So we had a 54-year-old healthy male foreigner palm oil plantation worker complaining of painful loss of vision after being hit by a nail while hammering at work with no eye protection worn on the same day. At presentation, he had an OTS of 1 with a score points of 39, seeing counting fingers at 1 foot, with an absent RAPD. The conjunctiva was injected, not chemos. The AC was formed but shallower compared to the fellow eye. And we do not have the anterior segment photo, but we do have a cartoon that I tried to depict what we saw. There was a linear corneal laceration wound at about 1 o'clock position, extending to almost the paracentral region, measuring 2 mm, with iris tissue plugging it. There was an anterior capsule breach with sublux lens noted. So the fellow eye was unremarkable, seeing 6.6. CT scan at presentation showed no intraocular foreign body, no metallic intraocular foreign body, confirmed breach posterior capsules with fragmented lens. So the acute management was tetanus and given IV ciprofloxacin stat, and proceeded within less than 24 hours for primary repair of cornea, lens removal with prophylactic intravitreal vancomycin and Fortum. Post-trauma day 2, and that's when the action starts. Right after the surgery, 24 hours upon opening up of the iPad, we could see stromal infiltrate starting to develop at the point where you can see the arrow here. That's the point of initial corneal injury, and there was already heaps of corneal stromal infiltrates with hypopyon, and there were loose sutures there as well. So the B scan showed vitreous opacities. There was absent fundus view, and it was dim red reflex. So we proceeded with those other drops. We was given ciprofloxacin, gentamicin, atropine, and the patient was planned for corneal scraping in view of the corneal infiltrates and urgent PPV, which was performed within 48 hours of trauma with an AC washout, at which point I did a total capsulectomy. And we gave empiric intravitreal of not only Vanco and Fortum, but this time around we added amphotericin B, considering that now it's already an infective case and where the patient came from with possible vegetative infection. The staining results at that point from only showed vitreous KOH staining, which showed fungal elements and confirmed our worst fears. CNS results eventually showed Bacillus cereus from the iris tissue that was plugging in, which was excised. Bacillus cereus on the vitreous with trichodema, which was much more scanty in growth to this extent that the microbiologists think that it might not be that significant, but compared to the Bacillus cereus load. The corneal scraping, which was done prior to the PPV on the same day, showed trichoderma as well. Fortunately, they were all sensitive to vancomycin and amphotericin B. So we started the patient on vancomycin and amphotericin B topical round the clock, atropine, and in total, over the course of the next 2 weeks, received 6 intravitreal vancomycins, 5 intravehicle amphotericin B in every 2 to 3 days over a period of 14 days. Systematically, we co-managed with the infectious disease team who planned for vancomycin for 6 weeks and amphotericin B for 6 weeks. However, the patient developed acute kidney injury due to the amphotericin B, which was subsequently replaced with oral fluconazole. He received OD or PEER and NSAIDs, so there were no steroids given. So over the course of 14 days with repeated injections, he demonstrated clinical improvement with clearing of the anterior chamber, clearing of the cornea and the vitreous cavity. The vision actually improved to something meaningful like 636. And the patient was, well, he's a foreigner, so we were trying to discharge him as soon as possible. And so at that point, we wanted to, since he improved and responded to treatment, we wanted to convert to an oral, and later on the reported sensitivity when we checked with the lab was also sensitive to ciprofloxacin, so hence we discharged him oral ciprofloxacin and NSAIDs, and after 14 days he was home. And that is more or less how he looked like close to discharge. The cornea cleared up and you can still see heaps of stromal infiltrates there, but the epithelial defect that was there previously closed up over the course of 14 days. So we were confident to let him go, and he had a very good employer who was very diligently bringing him quite frequently to the clinic. So over the course of 6 months, we were very pleasantly surprised that he improved to 618 best corrected. And this is the current situation now, and because of the COVID-19, his secondary IOL placement is delayed, so he's still aphakic. So the questions that I would like to raise to the panelists to see the opinions of the experts. In which cases of penetrating trauma would you consider not giving subconjunctival steroids at primary repair?
If there's any concern for fungal infection, so
when we suspect a fungal infection, when the injury is by vegetative products.
Actually, in our setting, we never give a subconjunctival steroid at the end of a repair. Routinely, we don't do it.
Okay. Yeah. Thank you. So second question, how early would you consider placing a secondary IOL in your opinion?
I would wait as long as possible to make sure, because you saw, I mean, the cornea doesn't look great. So I think I would.
Normally, we consider it within 2 weeks, 2 to 3 weeks.
After the infection is over.
Yeah.
First, we have to look at the infection, because there's still at 14 days also the cornea was not good. So I think infiltrates were there in the cornea. So we should wait in such cases. I think we should wait for long, and the patient is elderly, so there is no chance of amblyopia. So we can delay it to 2 months, 3 months after the infection is over, because there is a chance of recurrent endophthalmitis.
I agree.
Yes. Which brings me to the third question. Any particular preferences for a secondary IOL placement, or any preferences not to place a certain placement of secondary IOL?
So, shall I give the reply?
Yeah, welcome, sir.
Dr. Mukherjee, sir, please reply.
I think after the initial infection is over and the inflammation also, both the things are to be taken into consideration. And then one can plan for the secondary IOL. And then my preference would be, it will be the sulcus fixated IOL.
Okay. Sulcus fixated or scleral fixated, would you consider scleral fixated?
Scleral fixated.
I think if we have Dr. Caroline Chi, can we give her opinion for this?
I think Caroline is not there. Caroline, you are here?
Yes, I've just managed to get in. I mean, I was watching I just got onto the panel section. Is there an anterior capsule still?
No. So I did a complete capsulectomy. So there's no support. There is some iris support, although it remains mid-dilated, but it's not too bad. So my question was that, is there any reservations that you might have to put a scleral fixated IOL? Because nowadays we just go directly transscleral and with just the conjunctival lining. So how confident will you be that the communication with the external environment would there be any relative contraindication, or it's not an issue in this case, in traumatic endophthalmitis cases?
So in these patients, I suppose retrofixation would be could help. Retrofixation of light.
Dr. Rupesh?
Yeah, Dr. A couple of points regarding primary repair and the status of the lens, if I can. So basically, you said you did iris excision. So there is something which the audience, again, for the benefit of the audience, so you said in 24 hours, and I suspect the iris was viable and all, but particularly if we really see the injury and the iris is really bad, I will probably go for iris excision. So that is one way to kind of prevent the infection, because if you just touch and then if you really clip the iris which is spouting out, sometimes you may be leaving behind a stump of the iris which may have some bit of infection there. Then, though you picked up PC dehiscence on the CT scan, so I don't know how reliably, means most likely it was a PC dehiscence at the beginning, but then there are certain other tests to pick it up. And if it was really badly ruptured lens, then yeah, we are justified in removing the lens at the primary sitting. But if the lens matter was not bad, because right now I don't have a picture to kind of comment about it, but if the lens matter was not badly ruptured and there is not a lot of lens matter, I will probably just go for a primary repair, give antibiotics and all, because that barrier of PC is a quite an intact, nice one for preventing endophthalmitis. So sometimes you remove that barrier of posterior capsule, you allow the infection to go from front to behind. So therefore, and then also when you do more at the beginning, then chances of causing a lot of post-operative inflammation is also there. So those are the couple of consideration again, when you kind of think about primary repair and doing bit of extra surgery, and then you lose the PC at the very beginning, because if you do it at a later stage, like 1 month, 2 months, then you have a chance to do lens aspiration, controlled lens aspiration, and probably put in a lens in the back, which is always the good size, you know? Yeah.
Actually, the capsule was intact in the primary surgery. The minute the patient developed endophthalmitis, that's the point of referral to me. When I went in for the secondary PPV, I removed the capsule, so it was intact in the first primary surgery repair. But I take your point, and I agree. As much as possible to maintain barrier from the front to the back.
I would make a comment on the timing for surgery, particularly.
Yes.
I agree with Fasika that I would prefer to wait longer. Even in a case where there is no endophthalmitis, I would have waited about 3 months. It takes a lot when you are planning a procedure like a scleral fixated lens with a vitrectomy, maybe if needed. You are going to have a quieter eye if you have waited enough. And in those cases where there has been some posterior capsule remnant, you may find it has fibrosed enough to allow you to put it in front of the fibrosed capsular bag. So 3 months would be my time, but in a case where there has been an endophthalmitis, that waiting period would extend further.
Okay.
Yeah, just one comment. It's actually a great case, and the way you manage. We are not always so lucky when you have these type of mixed infections.
Yes, correct.
And yeah, and especially another good thing is you could identify both the organisms. Many a times what happens is you will be looking at only bacterial, and it's only our PCR which is showing a pan-fungal genome, and you are confused whether now we need to give a steroid, because Bacillus cereus also causes a lot of inflammation, and you may lose the eye because of the inflammatory reaction rather than the infection too. So I think the way you managed was extremely good. Only some things like which I was thinking that probably once it is a vitrectomized eye, your frequency of injections, if you are giving an antifungal, you need to probably repeat every day. It washes out quickly. every day for till initial time, and every second day we give the antibacterials. Now, depending on the clinical situation, definitely, but initial period we would be little more aggressive in managing them. Another thing was he had developed some renal injury because of probably the antifungal.
Yes.
And if I probably misunderstood it, you've still continued the non-steroidal anti-inflammatory, because that is something which also increases, because that you need to stop. That's something which I missed, that you should avoid using a non-steroidal anti-inflammatory if there is a renal injury, because they are also renotoxic.
Yes, so it was only given on PRN basis for the injections in the first week, but the minute he developed
And so it
AKI,
becomes a very difficult situation that you cannot give steroids, you cannot give non-steroidal, and there is inflammation. So I really admire the way you manage this. I think that was my comments. There were some of these observations.
Thank you very much. I think we were very fortunate that the organism was very sensitive. So take-home message is a high index of suspicion, and consider, as Dr. Fasika mentioned, vegetative infections by location, nature of injury, and early treatment intervention might help and save despite having poor prognosis.
Just one question to the panel. If on you could not, when you did your initial vitreous tap or aqueous tap, it was only a bacteria. Now, as I was telling, it's a pan-fungal genome which is positive on a PCR. Now, will you still, what would be your, because is it a contamination? It's always that query, and that sometimes causes a confusion in your management, especially in these type of trauma where you suspect a polymicrobial. How much you will give weightage to a PCR diagnosis during your management of endophthalmitis? Anybody in the panel who could just give me some, because we do face these problems sometimes that everything is initially your KOH, everything is negative, but the moment you look into your PCR report, you get pan-fungal and Eubacterium genome positive.
I think in this case where it's, I think in this case where the injury, is suggestive that it could be, there could be a fungus, it's consistent with a possible fungal infection, then you should take it seriously. Whereas if it was, say, a metal foreign body, it's less likely, then you might prefer to wait a while. And I think with fungus, you may be able to wait because it usually develops more slowly. You be careful with using steroids, because steroids could also, make it gallop along much faster.
Thank you, ma'am.
Thank you all. Due to the paucity of time, there are many more speakers left. So thank you, Dr. N, for initiating a very good discussion and showing us a very beautiful case. And may I request Dr. Mehul to invite another next speaker?
May I invite Rajiv to present his case, vitreoretinal surgery during COVID time. Dr. Rajiv, please.
Dr. Rajiv, you need to unmute yourself.
We are not able to hear you, Dr. Rajiv. Dr. Rajiv?
Sai can unmute, the host can unmute.
Sai, can you hear? Can you unmute Dr. Rajiv?
Yeah, now I could do it. When I was sharing the screen, I could not do that. Can you hear me now?
Yes.
Thank you. It is a real pleasure being in this webinar, and I would like to thank Dr. Ganga, Dr. Purendra Bhasin for giving me this opportunity to present some of the experiences we had dealing with vitreoretinal trauma during the lockdown period. And this is one of the paper which came from New Zealand. And definitely what we are seeing now, the pattern of trauma has changed. There has been reduction in injury-related admissions, and even we are seeing more injuries at home, particularly fall. This was a data from New Zealand. And in India, we have been having a long lockdown. And there are also some reports from India. So this is one of our trained fellow from Shankar Nethralaya, Dr. Manish Bapaya, who recently published the bow and arrow injuries. That there is a resurgence of this because of these two serials which have just started, Ramayana and Mahabharata. And that reminded us of one of our work in '94 when these serials were going on. And these are mythological serials where bow and arrow is used very commonly. And we had nearly 233 cases over a period of 4 years with bow and arrow injury. And when we tried analyzing it, nearly a third of them were inoperable. And one thing which we realized that the broken arrow tip is usually retained in the eye. So I think this message I thought again should go, because again we may see some of these type of injuries coming up. During the first and the second lockdown at Shankar Nethralaya, we saw about 35 patients with ophthalmic trauma. And I would describe 3 cases who had a blunt trauma, blunt injury with a shuttlecock while playing badminton. So we had the first lady, a young lady having good vision and had Berlin's edema. Another one who had a bit of hyphema, raised pressure, also having Berlin's edema, but not involving the fovea. And the third patient, again a young individual, more with the anterior uveitis, not having any other features. So what we saw that badminton, this shuttlecock injuries are usually a blunt injury. They can present with a variety of features, but if it is with Berlin's edema, usually they have a good prognosis, vision comes back, but sometimes when there is a irreversible photoreceptor damage, you may land up with less vision. However, when we were just looking at this shuttlecock, we had another patient with an unusual presentation. This is not during lockdown, just before lockdown. We had an 11-year-old male who reported at our emergency at a Calcutta center, who had a history of trauma to the right eye 2 hours back from a projectile nail which came out from a shuttlecock while playing badminton. And vision was less. And this is the external photographs. We had the nail which was abutting into the eye. And the patient was nilperorally for more than 6 hours. So we immediately took him for surgery, did a IOFB removal, scleral tear repair, intraocular antibiotics, and a cryo under general anesthesia. And intraoperatively, the patient was pretty lucky. The entry point was in pars plana, 3 millimeter from the limbus. And it was a large, the needle was large. It's about 20 millimeters. We sent it to a microbiological analysis, which was negative. And patient came back at 6 weeks with a pretty good vision, except for some slight vitreous condensation temporally in that eye. Otherwise, the eyes were normal. So this question came, we never heard of shuttlecocks having nails in them. And there were many unanswered questions. Where did the nail come from? Was the patient or attendant was lying, or did somebody throw a nail at him while playing? Did it come up from the indigenous racket, which many of us use? Or are nails really used in manufacturing shuttlecocks in India? So my fellow, one of our fellow, he went and brought both the shuttlecocks, the indigenous shuttlecock and what routinely people use, and we dissected it. So this shuttlecock was a good one. Nothing was there. And this is indigenously made. You can see there are nails which are there at the junction of the feathers and the cock. And there were not 1 or 2, but 4 of them. And we even dissected it. There were many other nails inside this shuttlecock. So we tried looking at literature. Anybody has reported a injury like this? So all cases have been reported blunt trauma because of a shuttlecock injury, except for Kelly et al., who reported a shattered glass, spectacle glass, and we didn't find similar report. And in this issue of Indian Journal of Ophthalmology, we published this as a rare case report. So we need to be beware of this locally made available shuttlecocks, and especially now when we will have more of these indoor games, or no, people will not go out to the grounds to play. We may get these types, especially in the urban areas, and there can be unusual injury associated with this game. And it is important to use protective eye gear, especially the polycarbonate glasses. And this case also highlights the importance of immediate surgery. You can get a very gratifying results. Just to conclude, in these COVID times, the profile of ocular trauma has changed, and we are seeing probably in India, urban areas, you may see more of these shuttlecock injuries. You may see more of bow and arrow injuries. We need to follow the new norms which have been set in by all these associations, and we need to intervene early. On the right side, you see one of the innovation which we have done at Shankar Netralaya for giving regional blocks, aerosol box for regional blocks, so that we can minimize the chances of, because during a local anesthesia, about 25% of people develop sneezing. So this is just one thing which I wanted to share. I would like to thank Dr. Pradeep, Dr. Veer Singh, our fellow who managed this, Dr. Sudipto and Dr. Kumar Saurabh from Calcutta, sharing this important case. Thank you very much.
Very
Any
nice
comments,
case.
I would be happy to take.
Pradeep, very nice case. Excellent case.
Very good case, very well managed.
Normally
Dr. Ganga wants to say something. Please, Dr. Ganga.
No, not really. I just wanted to compliment beautiful presentation, documentation. And sometimes when we go for indigenous ports and other industries, how sometimes we don't realize the price that we pay. And this kind of highlights the value of regulation in prevention of ophthalmic trauma. Just that's all.
Absolutely.
Absolutely.
Just want to remind everybody that most of the time with the shuttlecock injury, you get a blunt trauma to the eye. But in this case, because of the nails, it's very rare. Because of the nails, you had the perforating injury going in almost up to the posterior fold. Very nice case, very well documented.
Thanks.
Dr. Natarajan, can we discuss on this? Your expert comments.
No, it's an excellent case, and I think morning only I was talking to Raju about ocular trauma, more domestic injuries, and I was just thinking that no sports injury, and I see this shuttlecock injury. So I think that was an impression nobody's playing, but I think maybe some people are playing in their own compound and having this problem. So I think everybody should use protection, as we concluded, which we are trying to do as an ocular trauma society. I think to promote, they should have protective gear. Somehow the sports people, particularly in India, and we don't have any standardization unless like the North America, they have a standardized protective gear made of 2 mm thickness PMMA, which is there in US and Canada, but we don't get it, and Indian optical companies are not making it. I hope that if some of the optical people are seeing this, I think they should make sport protective goggles which will be user friendly for the person to play. I think I remember Ashok Grover and even Ganga Singh that we are all talking about management, but I think we all simultaneously, we should, some of us have to spend as an office to prevent injuries as well as activity with the government.
Absolutely correct, sir.
Wonderful case, Rajiv.
Wonderful case. Shall we go to the next case, please?
Sure.
Sure. Thank you. I would like to invite Dr. Yunia. Are you there? Dr. Yunia Irawati is from Jakarta, Indonesia. She is a orbit, ocular plastics and reconstructive surgeon. And she does cataract surgery also and refractive surgery as well. And she practices on the principle of 3 pillars of higher education comprising education, research and community services. So welcome Dr. Yunia to the group, and we look forward for our penetrating ocular trauma case presentation.
Thank you. Hi, good evening, everyone. And thank you, Dr. Purendra, Dr. Mehul, and Dr. Ganga for this opportunity and for sharing of my case. I'm very happy to join with you in the wonderful webinar meeting of international trauma. I have one patient during the COVID pandemic, 36 years old male with wound on the right eye. Patient did the cleansing on the gun at his home 2 hours before admission. Accidentally, the gun shot with a distance less than 30 centimeters, and it's around bullet hit on his right eye directly. During this time, he used the spectacles, and it was broken directly after hit by bullet. He suddenly felt a blur vision, severe pain, and bleeding from his right eye. Before this accident, the patient had a normal eye with the condition, no previous history of or periorbital disease and surgery. For the systemic condition patient was composmatis with normal vital sign and no ABC abnormality. From the ophthalmological status, for the right eye with vision, no light perception, we cannot examine the intraocular pressure because the huge of the wound, and there is a multiple laceration in the central to the peripheral, 1 millimeter from the limbal with the uveal prolapse. The lens was luxation with a vitreous prolapse, and there is iridodialysis. We cannot see or examine the RABD, and we could not examine the posterior segment. The left eye is normal. This, based on the location of injury, we sure it is the anterior segment and posterior segment location of injury. And from the Birmingham eye traumatology, the classification, I think, as we know, the eye injury can divide it into two closed and the open globe injury. And in this case is a patient with open globe injury with laceration, penetrating, and intraocular foreign body. Based on the open globe injury classification, we can make the diagnosis, the type of the penetrating with intraocular foreign body, grade visual acuity grade 5, and the zone 1. And there is additional diagnosis like iridodialysis, lens luxation, vitreous prolapse, and even the retinal detachment. The important additional investigation for the eye injury, we can do the X-ray with or without the Comberg test, and then the CT scan, MRI, or USG. In this case, we perform the X-ray, and then the result there is intraocular foreign body, but no any orbital fracture. And then for the initial treatment, we stabilize the patient, cover the eye trauma with ICID, give it the antibiotic broad spectrum eye drop and systemic, and give the systemic analgesic and tetanus prophylaxis, and preparing for the surgery. And how about the prognosis of the patient with the ocular trauma score? If we look the prognosis based on the ocular trauma score, the patient had the initial visual acuity is no light perception. It means the 60, and then there is glove rupture, perforation, and retinal detachment. The total score is around 12. It means the OTE score is level 1, and this is a pandemic situation, and the patient was being so concerned to undergo follow-up as well as another surgery. Therefore, we could apparently predict the poor prognosis for this patient. And we did the evisceration for this patient. We put the implant with the dermal fat graft to prevent the anophthalmic socket problem on the future. This is the bullet when we take out the evisceration. And this is during the operation when we look, we cleaning first. We would like to know how it happened in the anterior segment and the posterior segment. I think the wound is very severe because the bullet hit his eye with the length of distance of so short with the gun. And we do the thermofat graph and then put the conformer. And for the questions, maybe I have a question for the panelists. What is the important additional investigation and treatment should be given in this patient? And the second.
Dr. Kasturi, please comment.
Unia, thank you for your presentation. And I'm happy to say that in February, she reassured us there's no problem of COVID, and we all went there. I inaugurated the trauma center in Jakarta Eye Center on behalf of APOTS. Thanks to Unia and the team. But here, did you do the primary evisceration on the first surgery itself?
Yes, of course, it is dilemmatic for me. Yeah, I'm oculoplastic and then I'm an ocular trauma doctor. I already suggest to the patient to close the wound first, but the patient reject because this is a pandemic, and then they don't want to come back frequently to the hospital. And if the prognosis is very poor, he don't want to use many kind of surgery. But maybe from your experience, because I have a question, the second question is what is the best management for this patient? Can we perform one-step surgery to extract the foreign body, or is in the surgery to perform the multiple surgery?
You can do that, and I think now with the wide-angle observation, if you have some part of cornea, even a 2-3 millimeter area clear, in spite of doing the suture, may be able to do it. You can locate the foreign body and do it. Somehow, primary evisceration, I don't know, I understand the COVID situation, but you can remove the foreign body in the same setting also. But the problem is visualization.
What kind of technique did you use? Did you use the like magnetic to extract the bullet, or because it's difficult to find the bullet directly because of covering with the content of the.
You use the magnet with full visualization and not a blind using the magnet. If at all you use the intraocular magnet, bring it to the mid-vitreous cavity and then remove it through the limbus.
So anybody, Dr. Kasturi, what will you like to do in such case?
It was very nicely presented by Dr. Unia. Congratulations. But I would like to give some opinion regarding the management where you have mentioned evisceration as a treatment of choice. But usually in trauma patient, we know that during evisceration, there can be so much a release of this immunologic substance like the S antigen, the ERP, all those. And there are reports which literature says that the chance of sympathetic ophthalmitis is around between 5 days to 66 years. So we should always keep in mind, like initially to avoid this, we used to do only enucleation in such situation, but nowadays they have developed modified way of doing a evisceration in order to prevent the sympathetic ophthalmitis where they just keep a scleral frill. So that is my only hesitation. Like I would have, had it been me, I would have preferred to do a enucleation because the socket as such was healthy. Like we could have given a very nice implant, only with a fear that because I have seen patients developing sympathetic ophthalmitis even in my experience after 17 years. So I better not to take a chance. But or if you do a evisceration, it should be just to remove maximum amount of the uveal tissue and just keep a frill of the sclera.
Thank you.
Thank
So,
you.
Dr. Mehul, you want to add to it?
I think, as Dr. Natarajan said, that we always have to try and salvage the eye. Endoscopic surgery can be one of the options which can be utilized for the same.
So,
Dr. Ganga wants to say something.
if it is a lead pellet, magnet will not work. Is it a lead pellet, Unia?
Yeah. Yes.
No, if it is a lead, magnet will not work.
Yes.
So that's why myself and Manish Pape and Mahesh Sharma, we have designed a 4-pronged forceps, which we use for removing 4 into 4 millimeter pellets. And this, what was the diameter of this pellet? This one?
The diameter of pellet is 7 millimeters diameter.
So maybe you would have a different prong which will open bigger and then can grasp and remove it.
Right.
Dr. Mukherjee, you wanted to say something?
No, I was thinking that these days mostly the concept is that to preserve the eye as far as possible, rather than going into evisceration or enucleation. These days hardly evisceration is done. And for another point is that whenever the patient is seen on the first day or the first time, his mental condition may not be that same as you see the patient after 2 days. He may change his mind and go in for the multiple surgeries. And maybe the eye could have been saved without vision, but that is also cosmetically very important.
Yeah.
So I think we had a nice discussion. Any comment on it? So otherwise we will proceed to the next case.
Just one thing, that sometimes when you have a corneal laceration and you have IUFB, you are worried about endophthalmitis, we do many a times combined procedure where we do a PK along with temporary keratoprosthesis and remove the foreign body. I think when you have this doubt, that can be one of the procedure which you can think of, you can do.
If the vision is there, I would have preferred that, Rajiv.
Yes, I agree with
But
you.
there is
I agree.
no PL.
It is not for NPL, but I'm telling you, if vision is there, those type of procedures can be tried.
Thank you for the wonderful case, Dr. Unia. We will proceed to next case presentation.
Dr. Akshay. Can we call upon Dr. Akshay?
Dr. Akshay?
Yeah, I'm here. Dr. Unia, if you can stop your screen sharing, then I can start.
Okay. Stop screen sharing.
Dr. Akshay will be speaking on canalicular tear repair simplified. So I would like Dr. Grover and Dr. Ganga to comment on this and discuss at the end of the presentation.
Hello, I hope my slides are visible.
Yeah, visible.
All right, sir. So I will be talking on canalicular trauma and a simple the simplified management of canalicular trauma. Lacerations or damage to the canaliculus are the most common form of injury whenever the lacrimal system is involved. In spite of different techniques and different stents being used and different methods of identification, the 4 core principles of a canalicular tear repair have remained the same over the years, which is to first identify the cut ends, the proximal and the distal one, under high magnification in the microscope, to approximate the lid margin, to ensure that there is a stent placed through the lacerated canaliculus, and then to create a pericanalicular anastomosis so that the stent within the canaliculus remains as a splint around which there is pericanalicular epithelial healing, thereby maintaining the patency of that tract. The most common use, the stent being used commonly is the Mini Monoca, which is designed by FCI. It was designed by 2 French surgeons, Dr. Fayet and Bernard. It is silicone, medical grade silicone inert, and has a self-retaining hammerhead dilatation at one end, where it stays within the puncta and doesn't need to be sutured. Now, why does the lower canaliculus get damaged most often? So this is a wonderful paper in 1991 by Luke and Artwell, where they took fresh cadavers and with a forceps, they held the lower lid and created a tangential distraction force. And regardless of the direction, whether it was anterior, downwards, or laterally, the laceration always happened at the canaliculus, which shows that the canalicular area is the weakest area in the lower link in terms of the anchoring of the lid to the bony structures, which is why most commonly the lower canaliculus is involved. In India, we have a very unusual mode of trauma, which is a canalicular damage, which is called FACT, feeding associated canalicular trauma, where children, infants who are being breastfed by their mothers, inadvertently the hook, which is shown in the picture here, the blouse hook, engages the lower lid, and whenever the child moves their head, there is a distraction force created, and the lower lid, which is engaged into the hook of the blouse or the garment worn above, there is a canalicular tear. It is underreported, but very common. We have had informal discussions on oculoplastic forums and trauma forums, and this is very commonly seen. I quickly run through a video where the canalicular, the first thing here, as I said, is to identify the canaliculus. Now you can see that the pink ring of mucosal tissue here is the canalicular opening, the lacerated canalicular opening. There, irrigation is being done through that, and once it is patent, then you need to identify, make sure that the area is relatively dry. Other techniques include injecting an air bubble after putting a lot of saline over the lower area, inject a air bubble through the upper canaliculus. You can stain with methylene blue or trypan blue to see the area. You can put in a drop of epinephrine where all the surrounding muscle becomes blanched and you see only the ring of the mucosa. Then once you've identified, you take the mini monoca, you trim one end, the leading tip has to be beveled such that it slides in easily. You pass it through the proximal end and through the punctum. The self-retaining dilated hammerhead can be then pulled and snugly fit into the punctum. Following this, the canaliculus, the lower end is identified, and then the mini monoca is gently passed through it, caressed through it, and the end then coils up in the lacrimal sac. Once this is done, the stent is being placed, which acts as the splint. Pericanalicular anastomosis is important here. You can see that the sutures of the orbicularis that surround the canaliculus are taken carefully. The suture being used here is 6-vicryl, which is an absorbable suture. Especially in children, you don't want to put a non-absorbable suture for the skin as well, so that you don't have to go in for suture removal under anesthesia. You want to minimize the amount of anesthesia exposures, especially now during COVID times. When you tighten or fasten the sutures, the stent becomes a little loose, but it can be snugly pushed back in. Once this is done, the skin can be then closed in layers. And again, on the conjunctival side, you need to take 1 or 2 bites and then bury the knot so that it doesn't disturb the surface as the lid blinks. The laceration can then be closed in layers. Stent loss can be common, especially if children rub their eyes. Granulomas, like the one shown here, is a rare complication. Usually, patency is maintained as long as the stent is in place. The mini monoca is available, and this video is also visible on the mini monoca website. I have disclosed my financial interests earlier. So points for discussion for the panel include, in a low resource setting, like sometimes in the hinterland in India, or even in smaller hospitals, a mini monoca, which is expensive, is not always available at hand. So are there any alternates, and what the experience of the panelists with alternates? We've read in literature of IV lines being used and silicone rods being used. What is their preferred duration for stent removal, and the experience with their pigtail probes?
Dr. Ganga and Dr. Grover, please comment.
Dr. Grover first, please. Yeah.
Excellent presentation, I would say. And he has outlined the basic principles which are most important. I think The toughest part is identification of the medial cut end, which is much easier when the cut is relatively lateral. But when the cut goes medially, the canaliculus passes deeper, and that is when the difficulty can arise. But with most of us functioning and doing our repairs under operating microscope, it has become much easier. And he showed you the medial cut end beautifully. And that is almost always identifiable under the microscope itself when you pass the probe in its normal anatomical orientation. And that is the thing that is most helpful. As for the questions that Akshay has asked us, the alternatives available for canalicular stenting, we struggled through days when silicone tubes were not available, and we used some kind of sutures like proline and nylon sutures, and we struggled through silicone tubes which did not have any support, and we had to use various other means of providing some kind of support to get the tube in. But currently, the choice is Mini Minorca, quite clearly a good choice, and is available indigenously as well, making it simpler to use it. If it is not available, then the technique that we described in 86 of use of an intracath or 22 gauge is usually used. After cutting off the sharper tip of the needle that you use, you can then easily use that support to pass that Teflon material, which is an inert material, and retain it with the help of a couple of sutures passed through the end of the tube that is coming out of the punctum through the skin, and then give it an upward and medial direction by taking a double arm bite towards the medial canthus and tie it on a bolster. So that works very well. And the usual period of retention that we want is only about 4 to 6 weeks. Beyond that, you may have some side effects of the tubes with some bacterial collections and so on. So usually 4 to 6 weeks is enough, and you're able to retain it with the help of those kind of sutures. Works well. We've not had much experience with pigtail probe, as Ganga has done some. The theoretical disadvantage to that is the trauma that you can cause to the other normal canaliculus. But with inexpert hands, with well-designed pigtail cannulas, that may not be so much of an issue. Operated within the first 2 to 3 days, you have really approaching 100% results. But up to 5 days has been shown to be pretty safe with very high results. So these usually are the tips. And the Morrison's method that he mentioned for medial end identification by using a pool of saline when you inject from the opposite punctum, blocking the sac, is a very good giveaway to the location with the air bubble emerging from the medial cut end. And if you pass a small suture like a A2 or 6 suture just in front of the area where the bubble is emerging, we can very easily identify the cut end in the difficult case. Ganga.
Sure. Thanks, Dr. Grover. I think this is a great case and wonderful presentation. Just 2 or 3 quick points. I think, Akshay, you drove home the point that this is grossly underreported. These are children and young adults who have injuries, even go to the emergency room. And if you're not looking for a canalicular laceration, you're going to miss it. And even if you pick it up, if you're in an average ophthalmic setup where you don't have access to an oculoplastic surgeon, people just sew the eyelid anyhow and let it go. And we believe that every canaliculus, upper or lower in any age, should be repaired unless you're dealing with the 80-year-old woman. So point number 2 is when you have a lid avulsion with a concurrent open globe injury, a controversy always arises, should we do the lid laceration first or the globe injury first? Actually, this is a nice wide speculum. So basically the eyeball is much more exposed when the eyelid is avulsed. So you can do a better job with repairing your open globe first, and then go ahead with the lid laceration, canalicular laceration repair. And the last point is, again, if you don't have access to an oculoplastic surgeon in the middle of the night, this is one of the very few cases you can actually defer for 24, 48, 72, even 96 hours. And a lot of times you can repair it electively. So don't send children and adults away with canalicular laceration just because you don't have an oculoplastic surgeon. That's all. Thank you.
Actually,
Can I give some comment?
Yes.
Yes. Am I allowed to?
Of
Can you
course.
hear me?
Of course, of course.
Yeah, actually, we have at Drashti Netralaya designed a very special device which can easily find out the cut lacerated end of the canaliculus, where we find most of the time difficulty. So based on Dr. Grover's Teflon sleeve, the idea came in mind, and uh, simple 10 needle we just cut the sharp end, and we pass from the non-injured canaliculus, and one day it came out from the injured canaliculus. So that way we could find the cut end of the canaliculus, and the same stent we used passing through the distal cut end also. But then again, proline is such a strong suture, so we have come up with an idea. The needle, 10 proline needle-like structure with the blunt tip and back end will be a silicone tube, which we pass from the normal uninjured end of the canaliculus, and it definitely comes out of the cut end of the canaliculus, and the same silicone can be used as a stent also. Thank you.
Thank you. Dr. Shreya, we will move on to the last presentation, the next presentation by Dr. Mehboob. And may I request Dr. Mehboob, please? Dr. Mehboob Kadir is from Bangladesh, and he is a wonderful orbit-oculoplasty oncology surgeon. So, Dr. Mehboob, please.
Okay. Good evening, everyone. A special thanks to Dr. Ganga, Dr. Purandara Bhasin, and Dr. Mehul Shah to organize the webinar. I want to talk on eyelid lesion, a mysterious case report. A 15-year-old boy belonging to the rural area of Bangladesh, he came to us and presented with a painful swelling in the left lower eyelid, and pus come out from the left lower eyelid occasionally. He had gave a history of injury. He had fallen down on the ground from a TD. On examination, the lower lid was swollen, moderate tenderness, a blackish red crust on the left lower eyelid. A discharging sinus was found after removal of the crust. We ordered a CT scan of the orbit. A heterogeneous lesion was found in the infralateral part of the left orbit with subtissue swelling in the infralateral part of the left orbit and left lower eyelid. So our diagnosis was a retained orbital foreign body with discharging sinus of the lower eyelid. Explantation under general anesthesia was performed, and we extracted a wooden foreign body from the orbit. Patient and patient guardian was happy to see the removed foreign body, and he was discharged after 3 days of surgery with oral medication. Again, he came to us after 1 month of surgery with diffuse painful swelling in the left lower eyelid. On examination, the left lower lid was swollen, severe tenderness, yellowish pus point, periocular swelling also present, and left eye could not be opened. We ordered an MRI of the orbit, and we found a foreign body in the most posterior part of the orbit, and also orbital abscess extending intracranially. Re-exploration was done with a joint approach with neurosurgeon. We extracted 2 types of foreign bodies. One was little bigger, and another one was thread-like foreign body. So our diagnosis was retained orbital foreign body with orbital abscess extends intracranially. Orbital foreign body is an important cause of ocular morbidity, especially in the younger age group. Orbital foreign body can be impacted after a high velocity injury. Imaging study is mandatory to delineate the foreign body in the orbit. CT scan of the orbit must be ordered with 1 to 1.5 millimeter cuts of slices. CT scan may give false results if foreign body is less than 0.5 millimeter and initial stage of wooden foreign body. Odeon foreign body are better seen with MRI. We always follow the management strategy for orbital foreign body. Surgical removal is indicated for all types of organic foreign body. Vegetative or wooden foreign body is poorly tolerated than metallic foreign body. It provides good culture media for microbial agents, which leads to chronic discharging sinus, cellulitis, orbital abscess. Orbital abscess may extend intracranially. Now discussions, visual acuity, retained visual acuity good if the foreign body is located anteriorly, but posteriorly located orbital foreign body causes visual loss. All organic foreign bodies should be removed and inert small metallic orbital foreign body located near to orbital apex should manage conservatively if not causing any symptoms or signs. Now summary, orbital foreign body may present as chronic discharging sinus in the eyelid and requires an accurate and detailed history and meticulous evaluation of the patient. Imaging study, especially CT scan of the orbit, is essential for detection and localization of the foreign body. Early diagnosis, surgical exploration, and extraction, if indicated, provides get influence on visual prognosis and final outcome. Thank you all.
Dr. Kasturi, may I request you to please comment?
Yes, Dr. Mahmood, very nice presentation. And I also agree with you that the detection of an intraorbital foreign body in children is very challenging. And the most important challenge is in the diagnosis, because radiological diagnostic challenge occurs because of the varied presentation. And it has been many times seen that even if we do an ultrasound, to detect a wooden foreign body is very difficult because it gets interfered by the gas. And the CT scan, as you have very rightly mentioned, sometimes it may be misdiagnosed with fat and air. So the only option remains with MRI. So a history taking, and even if you want to do any imaging, it should be, I think MRI should be a preferred choice in such children. And you need to very meticulously manage it because the chances of bacterial infection is very high. So which Dr. Mahmood had done it very nicely. So the most diagnostic challenge for us is how do we diagnose? Because most of the times when we have an injury, we prefer an ultrasound. But many times the ultrasound causes hindrance because it gets interfered by the gas. This is what I want.
Dr. Ganga, any comments?
I don't think anybody can follow Kasturi, so I won't say anything anymore. She did a beautiful job. In the interest of time, I think we should move on. Congratulated Dr. Mehboob for the presentation. We got 2 more presentations, and I promise all the people who have asked the questions, we will address some of the questions. Dr. Mehul and Dr. Indra will address all the questions.
Thank you. Thank you, Dr. Mehboob. And I will request Dr. Shreya, can you unshare your screen, please? Dr. Shreya is from Drashti Netralaya, Dahod, Gujarat. She is a wonderful orbit-oculoplasty surgeon, and she has been trained from Shankar Netralaya. May I request Dr. Shreya to share your experience on lockdown? Can you make it short and sweet?
It's always such a sweet personality. Shreya, we cannot hear you.
Okay, am I audible now?
Yes.
Yeah. So I'm grateful to all office bearers and all my senior doctors and friends just to allow me to speak on impact of COVID-19 lockdown on ocular trauma at our area, our center. So we are lots of discussing since so long about the coronavirus, and we all know what coronavirus has done to us. COVID positive patients are the main source of infection, and person-to-person transmission routes includes direct as well as contact transmission also. And hence, the imposition of social distancing measures were implemented to prevent the community spread all over the world. And the lockdown announced from 22nd March in India. So that was the first lockdown announced. My slide is not moving. I'm so sorry. 1 second, it is. I'll do it again. Okay. In interest of not wasting time of others, if somebody can start discussion, I'll try my best to. And it's really interesting video.
Dr. Shreya, why don't you go to the video separate file? You leave this presentation, you go to the video file,
Okay, I'll do that.
you can see that circle moving. That means the presentation is hanged, the PowerPoint.
Yeah, it is hanged.
Yeah, so
So
you
I'll
go
do
to the
that.
video file,
1 second.
and in the video file, just click on the video, and then we should be able to see your video. Is there a video separately?
Yeah, I have separate video.
PPT से वीडियो क्या करेगा?
They will maintain social distancing.
He just wanted to say that you have only PPT and you don't have video, but I have video. If the time will allow and I'll be able to do, I'll do. It is only 3 minutes presentation. By the time I request the next Dr. Phasika, and we really want to hear her. So by the time it's only 3 minutes and it's not related with any of the presentation and everybody will enjoy. So I request Dr. Basin sir to start talk of Dr. Phasika. Till that time I'll do.
So please,
sorry for that.
Dr. Natarajan, can you please introduce Dr. Phasika? May I request Dr. Phasika to come to the forefront and present her experience on COVID?
Yes, good evening, everyone. Great pleasure to introduce Dr. Phasika. Phasika is at the Johns Hopkins University School of Medicine. He is currently the professor of ophthalmology in the.
Others, ma'am, please mute.
I think the list goes on, and her publications, I think, are enormous. She has done several publications, and I think she's also written several review articles, and also done philanthropy and intramural research. And I think the teaching, and the list goes on. And I think if I read, I think her presentation time will be over. But I think I'm very happy to say she's the director of Eye Trauma Center. And thanks to Rupesh for getting Phasika to APOTS and to our International Ophthalmic Trauma webinar. So hence I present Phasika to you.
Thank you so much, Dr. Natarajan. Can everybody see my screen?
Yes, we can.
Okay, perfect. Oh, so yes, that's a picture. This is a picture of our research labs in our theater. And so as I'm going to be talking today about the ophthalmic trauma in the era of COVID. I can't advance. Oh, okay, great. I'd like to thank everyone. Thanks, Dr. Natarajan, for that wonderful introduction. And I'd like to thank Dr. Ganga for inviting me. And I'd like to thank the moderators and the Ocular Trauma Society of India and APOTS as well. And of course, Rupesh as well. So I have no financial disclosures. And as we heard in the last talk, it was basically in March where our lives were turned upside down by COVID, and the World Health Organization declared the pandemic. So for us, the Academy on March 18th said we need to stop all elective surgery and only take care of urgent or emergent matters. So this was a case that came in during this pandemic. So, and you can tell that because you can see the patient is masked. And as Dr. Rahman had mentioned earlier, the epidemiology of the type of traumas is changing. So you can see this patient has a full thickness corneal laceration with uveal prolapse, and the reason is she was gardening. So we're seeing more injuries in the home with activities like gardening, which we'll talk about. And I think, Rupesh, I'm going to put in a plug for iGates. I think an iRegistry where we could monitor this sort of in real time in pandemics would be wonderful, because then we could instantly do prevention measures. So the Academy defined what urgent and emergent was for us. So emergent a threat to visual function immediately, and urgent would be a delay of several hours to days. So they actually defined what procedures would we count as emergent versus urgent. So here are our trauma well represented. So IOFB, open globe, canthelysis canthotomy for retrobulbar hemorrhage. And Dr. Ganga was saying canalicular lacerations can be delayed a little bit. So, but they have it here as emergent. I think just I think it could be urgent or emergent. And then corneal foreign body they have as urgent, and lid lacerations and orbital fractures as urgent. We also, Dr. Rahman also talked about the considerations for surgery. So at Wilmer, when we do our open globe surgeries, most of the time the patient is under general anesthesia. When I did my fellowship at Miami at Bascom Palmer, they actually did it mostly under a block. So of course, general anesthesia, there's more risk for increased transmission. And we've seen cases where the patient is not known COVID and they go under general anesthesia, and then they start to desaturate, and later we find out they had COVID. So I think in this era of operating when we don't know if the patient is COVID positive, we pretty much have to assume and wear the proper PPE. So in our emergency room now, they do have stat COVID testing, so it is available within a few hours. But in the beginning of the pandemic, it was not. So if we do know that the patient is COVID positive or having symptoms of COVID, then they have a special operating room for us. It's a negative pressure room. And as we said, I mean, it's really changed how we operate in terms of we're supposed to operate with the N95 now, wearing the shield. And that was a very creative shield around the patient, which I think, as you said, we're going to have to be innovative in our approach to this. And the other unique thing, I think, at least in the US, is that most of the academic medical centers are the ones who do the open globe. So it's mostly residents. I don't know if it's that way everywhere else in the world, but for us, the residents do, of course, with an attending, but they do the suturing. And so basically you teach them. So that's taking extra time. So there was some discussion, if the patient was COVID positive, we said that we basically were not going to let the trainee do it, because of course you don't want to prolong exposure of the nurses or anybody to COVID. But if they're not COVID positive, we're still letting the trainees be involved, just because they've lost all their surgical experience during this time for the last 2 months. And so Dr. Rahman also had brought up this article about the changing trends in ocular trauma during the COVID pandemic. So this was a study from Italy, one of the countries hit early on. And basically they just compared the period of time from March 10th to April 10th in 2020, and they compared it to the year before. And as expected, there's a huge drop in people visiting the emergency room. So it dropped by 68%. And again, I think the interesting part is what we're seeing a shift in the mechanism of injury. So sports injuries are going down because kids are out of school and because of quarantining and social distancing, we're seeing a drop in that, but we're seeing an increase. You can see the home activities here, injuries increased from 12.4 to 17%. Falls actually in this study went down from 6.5 to 0.9, which is interesting. And what else? And violence, assault stayed about stable. And gardening went up. So, and that was the injury that our patient had. So it went up about 2% in this study. And then I mentioned that sports and falls decreased. And when we just look at the injury of the diagnosis, the most common was a superficial injury of the cornea and conjunctiva followed by foreign body. And this is the other study that I saw on this topic, which was based out of the UK. And they also compared before and after 1 year prior, the exact same time period to adjust for the time, the difference in season. And again, they saw a drop of 35% in the normal volume. And again, it's coming out that there's lots of injuries in the home, gardening, home improvement, and 3 with exercise from elastic bands. And then the other thing is, are people, if they're having eye injuries or even emergencies, like are they not coming to the hospital because they're afraid to? So in this study, there were 3 patients with severe microbial keratitis who didn't present for 7 to 14 days. So just to talk about our experience at Wilmer briefly, we looked at the same thing. We looked at this period of time starting on March 18th when we were not allowed to do, where we were only doing urgent surgeries to basically now. And we saw that actually so we had 24, in this period of time, we had 24 trauma cases compared to 17 last year. And I think we can explain that number because a lot of surrounding physicians in the area aren't doing the trauma. So when we looked at the etiology, once again, home, 56% of the injuries occurred in the home. And then there was still some assault, and occupational was 24% for those essential workers. And then in terms of the type of eye surgeries we're performing, 58% were open globe. There were actually 5 IOFBs in this time period. And then lid lacerations, there were 3. And this was a corneal foreign body removal in a child where the injury occurred at home. So just in summary, we've seen overall a dramatic decline in numbers presenting to the emergency room. And we've seen a decline in the number of, well, not at Wilmer, but in the other 2 studies, they reported a decline in the number of trauma cases because people are staying home and not engaging in activities like sports. But we see that home injuries is increasing. So I think prevention strategies starting now need to be implemented for while people are quarantined, in terms of wearing their safety glasses when they're gardening or doing any high-risk activity. And again, we have to educate patients that if they have an eye emergency, that they need to come in even during the COVID pandemic, and we'll have to take care of them with the appropriate PPE. So that's all I have. Thank you very much again for having me. This has been very, I've really enjoyed the conference. So thank you so much for including me.
Thank you, Pratika, for a wonderful presentation. So I have a request and a homework for you and Rupesh. You analyzed the Wilmer's data, then the Italian paper, which was in Nature. So I said, why not whoever is in the panel now? Whoever is in the panel, am I audible?
Yeah.
Okay, so whoever is in the panel, whether we can collect the IRB approval, and can we collect data from all the institutes from whichever date we agree, and then make a joint presentation from APOTS? I don't know whether Rupesh.
Rupesh, can you hear? Can you listen?
Yeah. I have to think about before Dr. Natarajan has put up a challenge. Therefore, I am thinking about it.
So I would love to. So somebody at Wilmer, it wasn't me, but one of my colleagues was looking at not just trauma, but just all emergencies like retinal detachment, glaucoma surgeries. So I have the subset of trauma there that has an IRB approval, so I can hand that data over. And so if the rest of you could join, like you said, we could focus specifically on ophthalmic trauma. Yeah, and then on one of our, as everybody knows, our upcoming conference on that APOTS is co-sponsoring with us, there was a, I think Will submitted an abstract on this topic, so I think it's going to be, it will be interesting.
In your conclusion, you showed that we should use preventive measures at home injuries. I really don't know what will you recommend. So I think we have to probably recommend it in a big way from Ocular Trauma Society of India for India and from the world.
We have actually, we made the guidelines Ocular Trauma Society of India along with the All India Ophthalmic Society, and that is in the that is already published and that is followed, and that has to be regularly monitored because time is changing. Tomorrow what will happen we do not know. Depending on that, we have to change those guidelines. And I must congratulate for Pratika's presentation which is concise and very nice. And I have to add one or two points. Besides whatever protection that we take for ourselves or for the patients, we should do the clinical examination, documentation, and the management as quickly in shortest possible time, so that the patient remains in the clinic for minimum possible time, and the number of visitors should be minimum in the clinic, so the contagion is not spread amongst the other patients. So expert person who is regularly doing this job, they should take up these cases and do it. Third point is that what I thought, that if there is a polytrauma injury, it has to be taken care along with the other specialties. And fourth one, I feel that if there is a pole-to-pole injury, one has to take care along with the vitreoretinal surgeons. So these are the points that I thought that I should make.
Yes, sir. Sir, I think as you rightly said, AOS and OTSA has brought the guideline which is there in the IGO. But I think what I am talking is about home precaution, which has to go to the public. So as a APOTS and as a OTSI, and also from Fasika from Johns Hopkins, what is your suggestion? What do you tell in the televisions or in the e-newspapers which is coming? What do they use as a protective measure at home? Because usually they are nailing something, or the children are running here and there, or somebody is pulling the chair. So how do you prevent injury, and who will wear a protective glass while going to eat, or from bedroom to drawing room or a study room?
Sir, we have done a study from our institution and Dr. Purendra's institution, and we found there is a significant rise in ocular trauma in children during lockdown period.
My presentation is ready, Dr. Mehul. If you wish, I can show that the data. Everybody is allowing me. I can show my presentation is ready. I just deleted one slide.
Yeah, Shreya, we have a look at that.
Thank you, sir.
I would like to congratulate Fasika for that wonderful presentation and analysis. And it was a great pleasure, of course, having you at the World Congress and to hear your presentations then. The points that you made are very pertinent. The nature of injuries is one very important aspect. The second aspect that I wanted to emphasize was the changes in the management that we need to do. I think there is an increasing realization of the role of aerosols and droplets and airborne infection. It has become clear that our methods of using cautery, our methods of using drills, they will really have to decrease. So when we do the plating, we would avoid the drilling, we would avoid the use of anything that would generate aerosols, including the saws and so on and so forth. So we all have to alter our management accordingly. Managing lacrimal trauma has become an issue, especially going into sac and into the nose. So those issues will be equally important when we talk about the management of trauma in COVID time. And it will be wonderful to put together not just the data, but the advisories that can come from that for prevention, as Natarajan very rightly pointed out.
So I'm really extremely sorry to speak after Dr. Fasika ma'am, after the honored guest. I'm really sorry. So I was telling about the coronavirus disease and how it spreads. I had lots of video after this, so I had to delete this, which was not working. So in lockdown, after announcement of lockdown, we started our hospital with all due precautions, like all the sanitization chamber and PPT and whatever is said by government and non thing we did. We started the hospital with the idea that no travel, no accident, no school, no sports in school. So we decided that we thought that there should be less trauma in the lockdown. But then really we looked, is it really so? It was not. So we decided to call upon our near and dear and senior Dr. Basin sir. So we called him and asked him the same data, same thing what we observed. So we collected data from Dr. Basin sir's hospital, Ratanjyot Netralaya Gwalior and Drishti Netralaya. We analyzed those data and we came up with the study, effect of COVID-19 on lockdown on ocular trauma, and which study was compliance with the standard ethical practice. In our multi-center retrospective study, We collected data from AMR of all the both the institutes, and these data were from 22nd March to 30th April only. So that was lockdown 1 and 2 only. We have not enrolled the data from lockdown 3 and 4. And we compared the similar data between the same periods of previous year, keeping in mind that there was a restriction on interstate travel this year. And we came to know that this data were really, really surprising to us. If we look at the detail, we had 148 patients presented in emergency department this year as compared to 157. So it's not that much less. But out of them were 78, means 52.7% had ocular trauma this year compared with the 76 last year. So it has increased the rate. So who got injured? We think that obviously an adult got injured because of the lockdown and children were not allowed to go out, but which was not also true in our case. 30% out of the trauma were children and 33 needed surgery. So that were also a rise in the number of surgeries also this year that opened our eyes. And the compounding factor here being that due to the lockdown, only our district patients could visit us contrary to the last year. So again, there is a surprising fact. And in urban area, we think that children staying at home and they just get the injured. It is not so in our rural area. In rural area, this is the fruit which comes in this season and they sell this fruit. The name of this fruit is Gora Samli. In English, it is a jungle jalebi, and this is the biological name of that fruit. They sell every day. Now the children are not going to school, so they do this. They just get this Gora Samli from the tree, and we can see here also that it has got thorn. So that can be an injury from the thorn also. If they are not able to get the Gora Samli from this way, they just go on the tree and then they fall. So, and if they are not doing this, they are playing with the game, which are literally causing injury to eyes. So they are playing with the sticks only. So in our area, and these all games brought the ocular trauma ranging from lid laceration to the globe rupture to our institute. And so we can just conclude with COVID-19 lockdown had direct impact on the incidence of our ocular trauma, especially by the special Gora Samli tree, and especially in the pediatric age group. We searched for literature references from many places. We could not find any. We found one from the British, but they were also lacking of the data. So we could not get the numbers out of this study. So I just can't say anything. Stay home, stay safe. Thank you so much for allowing me to speak. Thanks a lot.
Thank you, Dr. Shreya. Any comments from anybody? Otherwise,
oops, I did want to say this is an example, Dr. Natra, of the glasses for kids. Like so, like my 4-year-old is always, I always make him when he's outside, like around trees or anything, because I've seen so many in kids. I've seen so many open globes that I'm paranoid. So then I bought, and it comes in like this. There's plenty of them. So it's like I think that would be the only thing that we could do to prevent it.
And these glasses are made of what?
They're not. I don't think they're polycarbonate. So, but they're. I mean, it would stop like if a tree branch or something. It's not like for the monocular where you want the unbreakable glass, but it's not glass. It's some sort of plastic.
Plastic, right? I think the only problem will be to make the children wear, and as Ganga has mentioned, that we have to explain to the kids and make sure they wear it. I think.
And they come colored, so they love to wear. My son and my nephew, they love to wear it. So I'll check what the material is, but it says they're safety glasses, and it says impact and scratch resistant. So
okay, something like that we have to make and sometimes the same, and then you have to supervise by adults and we say go to
the polycarbonate at least, it is said that polycarbonate are at least 250 times they are more harder than the glass and almost 30 times more harder than the plastic. So I don't remember now, when I was a student, I remember they say even if a iron ball moves at the speed of 30 miles per hour and hits a glass, it will not break into pieces. It will just smash. So hard it is. So I feel that every patient, especially one-eyed patient or the traumatic patient, polycarbonate should be advised in all such situation.
For home, this thing, I think Dr. Fasika, the swimming protective glasses can be used. What we wear for this during the swimming, that are soft and children can wear them.
That is severe. Cannot wear that.
Yes, sir. So, Dr. Ganga, Dr. Mukherjee, anything, any comments? Or shall we go ahead?
The problem is about how do you wear them. The problem is generally even adults, when they are playing and they feel that wearing the protective goggles are a problem, and then when they don't wear it, and those are the people who get injured.
I agree with Nati. It's much easier in an occupational setting or an industrial setting, or maybe the army men, or even for sportsmen. Right. Difficult at home.
Even for them, in India, they feel it's like hindrance. So anyway, I think we need advocacy and eye care awareness. Okay, carry on.
But one factor that we can take care of is about a lot of education about bow and arrows, because in this season that increase is not acceptable after the lessons we learned in the previous episode when this was so high.
So there are few questions. Can we take, sir? Dr. Mukti Mitra has asked, what is the maximum time limit of traumatic canalicular injury repair? What is the maximum time limit of traumatic canalicular injury repair?
Yes, Akshay, go ahead.
No, ma'am, Dr. Kasturi, please go ahead. Please go ahead.
Initially, the textbooks, they used to tell us that we should need to do within 8 hours. But now, if you see the written literatures, they say that safe time, even up to 5 days, it is considered that you can well manage within the 5 days.
Okay. Another question is it important to repair upper canaliculus injury? Doctor? There are a lot of questions which have come, and for your surprise, there were more than 1100 registrations for this meeting. So I think this is very heartening. And 128 were listening to this webinar on YouTube and some on Facebook also. So this is a question. Is it important to repair upper canaliculus injury?
Yeah, I think any canaliculus that is damaged, like Dr. Ganga said, canaliculus is a canaliculus, whether it is upper or lower should be repaired.
Okay. And another question, can we put a stent in a second sitting?
Secondarily, yes, you can, but we need to understand that there is a possibility that we may not be able to, if there is a severe scarring, we may not be able to pass it through. So it can be attempted. I have attempted a 2-month-old trauma with a little dissection. We were able to find it. Not always possible, but definitely should be attempted.
There is no way in which a primary intubation should not be done. You have alternative materials. If nothing else, you can even put a suture if you don't even have an intracat. So there is no reason not to put it. The only reason for re-intubating may be if a tube gets extruded. Otherwise, it should be done at the primary site.
There is a question. There is a question asking about the voriconazole versus amphotericin B. Which one is
for the intravitreal? Dr. Ayan, can you comment on this, Dr. Ayan?
Yes, thank you for the question. In our setting, amphotericin B is more cost-effective in terms of, especially for foreigners, and is relatively easily more accessible on an emergency basis. Voriconazole has good coverage as well, I think with less toxic effects, but
less toxic.
But in our setting, there's several filters that we needed to go, and permission from the infectious diseases and justifying why it's needed. So that would be time consuming. So in our case, we and judging from the sensitivity, we went on amphotericin B.
Can anyone comment?
No. Please keep it to amphotericin. Voriconazole, keep it for tough cases. If you use voriconazole as a first-line therapy, that's not something which is recommended. Always go with your amphotericin and all. Same thing applies for some other antibiotics, but focusing on the antifungal, I will strongly suggest to keep it to amphotericin. And if it is not responding, then consider voriconazole. Thank you.
There is a question for Dr. Shakeen. Would you not do an iridectomy of the prolapsed iris considering 3 days post-trauma?
Definitely preferable if you can do. Although if you have formed a tunes chamber well, then you don't need to. Safer to do, to say.
Thank you all. Dr. Gangab, can you please give a final comment on this webinar and your experience?
Oh, I think at the outset, I wanted to thank every one of these presenters. I think they did a phenomenal job. We managed to cover everything from front to back, anterior to posterior segment, and ocular nexa as well. And you also shared beautiful dilemmas in management. I think intraocular foreign body from Jakarta, from a gun injury. And I can imagine the heartache Unia went through when she did a primary evisceration in such a patient, even though you were consciously against it. So it tells you how much more stress that we go through in these kind of special situations, in addition to the medical risk that we all take, because all of us, number one, either don't take precautions or do not have access to all the full-fledged PPE that we are supposed to use. And we are all taking great risk by putting patients under general anesthesia, lacrimal intubations, and so on and so forth. Sorry? The second thing I wanted to mention is I think hats off to Dr. Mehul and Dr. Purendra for putting this together in such a wonderful manner. I know organizing a webinar like this is not at all easy. It's very hard to make everybody happy because we're trying to find the balance between quality, quantity, timing, audience participation. So I think hats off. Let's give a big hand to Purendra and Mehul. And this will not happen without the support of Dr. Mukherjee, the president of Ocular Trauma Society of India, Dr. Grover, Dr. Natarajan, Dr. Azad.
Thank you.
Lots and lots of people. I think it is the force that they are behind us which actually makes us do all this. Extra special thanks for Fasika for waking up so early in the morning on a weekend.
True.
With due apologies and a fabulous, inspiring presentation. It tells us that all of us should be collecting data properly. I think most of us are collecting this data, and I think we look forward to probably, let's set ourselves a goal, say within a month, to compile data from various institutions. And like Dr. Natarajan says, let's try to see it in publication. Rupesh will coordinate it. Sorry, Rupesh. But I think all of us will put energy and try to make it happen.
I think we can put Fasika as the coordinator for the present paper.
Absolutely.
And then
He's already collecting with the iGates. We just have to do an iGates COVID.
Yeah, I think we already have the data. It's just putting it in context. I wanted to compliment the 1,000 odd people who have registered, logged in to watch all these things. I'm watching feedback on a different group as well, and people are giving some glorious comments. We have Bangladesh, Indonesia, Nepal, Malaysia, in addition to India, Singapore. That tells you how truly this is an international ophthalmic trauma seminar. Remember, this is only seminar number 1 or webinar number 1. So we are indeed planning to organize the next one post WOC in July. Those of you who are listening to all this, I invite you to put your hand up and say, I want to organize the next one. I want the host the next one. Dr. Purendra will very happily pass it on to you. So do get in touch with us. And we are hopefully in September, the same days that Dr. Unia was supposed to organize the Bali meeting, which all of us were raring to go. We know the physical meeting is being postponed to next year, but that particular weekend we'll probably be organizing our 3rd APARTS webinar. So look out for July, look out for September. We will keep you all posted as you go along, but I wanted to thank every single person who's been both in front and behind the scene, including Sai from Numerotech, for making this happen. Dr. Natarajan, would you like to say a few comments?
Yeah. I would like to invite you all for the next 2022 meeting, APOTS meeting organized by Dr. Ayen. We will all be there. Dr. N.
Yes,
So
thank you for that.
To meet you all there also.
Yes, thank you very much. Yeah.
Dr. Fasika, your experience about this webinar?
I really enjoyed the case presentations, the discussions, and like Dr. Ganga was saying, really we see everyone's putting themselves at risk to take care of patients, so it's really inspiring. And we're just resuming activity on Monday, so so we'll just see how it goes. But I think everybody keep being careful. We had a patient where they're doing 100% testing and they had no symptoms and came back positive. So just please, everyone, be careful.
So, Dr. Rupesh, anything you want to say? Dr. Rupesh?
Actually, the meeting was very good and well conducted. And I think we can probably look forward for further webinars with probably focused topics. And as you say, there are definitely more attendees, but maybe we can give them more chance to interact. I think we can keep it interact. And there are multiple platforms for quiz and polling and all. And we can introduce some of those live where you can polling, because initially what I was thinking as a honest feedback is you can have learning objective number 1 and 2, what the audience has learned. And after that, at the end of it, you can do a polling again. So 2 questions before and 2 questions at the end of the thing. And there are platforms which are available, which I can share with you and which they can do it. And I think a great meeting, and look forward for more residents to come up, more cases to be presented, as Dr. Fasika is very nicely organized, and that will be on 20th of June, and where the residents will be presenting their cases so that we give them kind of a heads up in this kind of presentation, because they will be more free to present. When you ask them to present on the live, on the forum, they are a bit scared, but here probably they will be more kind of free, and they probably will present it. So that's one point. Another point which I've spoken to Dr. Ganga is as a PODS and OTSI. We should take this as an opportunity to create courses where you can create modules of 5 or 6 kind of webinars of 1 hour, 2 hour to take through the corneal trauma, lacrimal trauma, and all those things. Because if more people are attending, and then we can have that this as a platform. So this we can use it as an opportunity. But overall, thanks, and look forward for the next webinar.
And Rupesh, we had 120, over 120 abstracts for that we have to go through, and we're gonna have to narrow it down.
So once again, just to reiterate on what Dr. Fasika said, there were only very few abstracts to be presented, but we'll be talking to Dr. Fasika, and what we are trying to do is to give the top 10 presenters a free APODS membership for their lifetime, because these are the residents, and it will be great if we can encourage them, these residents, to become members of APODS, and who have some academic flair at the very beginning of their residency of the ophthalmology. So that's where we are trying to kind of encourage them, and those top 10 abstracts will be given like the free lifetime APODS membership, which otherwise can cost them quite a lot of money. So I think, and then they will be quite involved with you and then talking to you. So that's something.
Right, sir. Yeah. Great encouragement.
Thank you.
Dr.
Mukherjee, you want to say?
Dr. Mukherjee, you want to say something?
I think Dr. Rupesh has told whatever is done, but I must thank speakers for nice job they have done with good content, rather high volume content. They are very nicely presented in a concise manner. And I must thank all the overseas presenters for taking their time out in odd hours, particularly from USA, and take part in this webinar. And our presenters also, they have also done the good job. And I must thank Dr. Gangadhar and Dr. Purender taking part in organizing this type of webinar, which is so effective and so nicely organized. It should be done. And I would request Purinder to compile all the questions, and then those can be posted in our email so we can see them. And if you can just answer them, you can just put them into the website of the OTSI. That can be done. If you cannot, if you don't have the time during the webinar to answer all the questions, those can be compiled and then they can be put into the website. And I must congratulate all the persons who are taken part behind the screen, and that they are actually the people who have made this thing absolutely flawless. I had little problem in starting the webinar, but at the end I could manage it. And I must thank all the people who have taken part in this webinar. Thank you so much.
Great.
So,
Caroline, you want to say something?
Caroline, you want?
It's great. Let's see.
Yeah, you're on. You're on.
Yes, it's been a very good, it's been a very good experience. I think I've learned quite a lot, and I think I've also I'm also very impressed that it came across very well. You know, I mean, the presentations were very well presented, and I think we all learned quite a lot from it. And the discussion was great. I think we probably what we can take away from this is that we should give a little more time for discussion.
One point that I would add is we will need many more such activities by APOTS and OTSI must get to.
Yes, it's been a very good, it's the presentations were very well presented, and I think we all learned quite a lot.
Getting together OTSI and APOTS can really produce results which can be useful for all people who handle trauma everywhere.
So, shall we move out of this meeting? I think no one is interested to move out. Everybody is come to the screen. So,
Right.
I'm really so happy to see this.
All are extremely happy regarding the meeting.
And we apologize for the time which has got extended. But Caroline was saying that the discussion was time for the discussion was less. I think it has to be balanced, and we really appreciate everybody's efforts to make this webinar a successful one. Special thanks to Sai and the team, and undoubtedly Dr. Ganga for his valuable contributions and suggestions time to time. My dear friend Mehul, and undoubtedly no words for Dr. Natarajan and Dr. Mukherjee. Thank you all and all the presenters. Thank you. Thank you, Dr. Fasika. Let us move out of this and have a safe time, safe days ahead during the COVID period. Let us practice safely. See you next time maybe in July. And Dr. Natarajan has said, let us contribute to develop the number of cases which we have done in COVID times, and we can discuss among ourselves. So we will let Dr. Rupesh or someone prepare the questionnaire, and maybe Fasika, if you can share with us the questionnaire for the ophthalmic trauma, we can give us our data and we can prepare that. If your resident or someone can share the questionnaire, so we can share from our database to you, and which should be a basic one, so that we can come to know about the number of trauma cases in last 2 months everywhere in the world.
Even those questions answered out of this webinar, you just compile them and put it into the website or send it to us.
So that we will be doing, sir. We will do. I will ask Sai. We will send it to you, to all the people. Thank you all. Thanks a lot. Happy.
Thank you again,
happy,
everybody.
Thank you. Bye bye.
We'll be in touch.
Namaste.
Thank you so much.
Thank you. Thank you so much. Thank you, Sai. Thank you all.
Thank you, Sai.
Thanks a lot for acknowledging, Doctor.
Thank you.
Sai Ram. Sai Krishna.
Sai Krishna. Thank you, Graham, for being with us throughout and for giving your valuable contributions in electrophysiological studies. Thank you, Mahbub.
Thank you. Try and more next time.
Thank you.
Good night.
Bye. Good night.